Usually when we think about severe pain, we conceptualize it as like a red flashing light on a car's dashboard.
Right, yeah.
It's the body's ultimate, undeniable alarm system just screaming at you, stop whatever you are doing. Something is fundamentally broken.
Exactly. I mean, it functions as this evolutionary warning sign for self-preservation. Like, if you touch a hot stove,
You pull your hand away.
right, the pain forces you to pull your hand away before the tissue literally burns. Or, if you sprain an ankle, the pain forces you to stay off it so the ligaments can heal. So the equation is usually very simple, which is pain equals damage.
But then you look at human labor, and that entire biological paradigm just gets flipped completely upside down.
It really does.
Because the alarm is absolutely blaring. I mean, louder than almost anything else a human can experience, but nothing is actually broken. The engine isn't failing. It's just, doing exactly what it was built to do.
Which represents a truly fascinating biological paradox. Childbirth is one of the very few times in human physiology where intense, overwhelming visceral pain is actually a clinical marker of healthy forward progress.
Wow, yeah.
And because the fundamental nature of this pain is so unique, the strategies that medical professionals use to manage it have to be, well, incredibly creative.
Welcome back to the deep dive. We are thrilled you're here. We always design these discussions specifically for you, the learner. Because whether you are currently planning a family or preparing to support a partner in the delivery room, or you are just insanely curious about the outer limits of human physiology, we're looking at the ultimate test of the human body today. We're pulling insights from a really comprehensive clinical text called Pain Management Strategies for Labor and Birth. Okay, let's unpack this.
So our mission today is to completely demystify labor pain. We're going to break down exactly what is happening in the nervous system, explore the underlying mechanics of why it happens, and really examine the fascinating toolkit modern medicine uses to manage it.
Because understanding the architecture of the pain kind of changes how we see it, right?
Absolutely. It fundamentally changes perception.
And perception is a massive piece of this puzzle. But before we get into the psychology of it, let's start at the physical source. Because reading through the source material, I realized I had this huge misconception.
Oh, really?
Yeah, I thought labor pain was just one continuous uniform sensation that basically just got worse over time.
Right. A lot of people think that.
But the text points out that it actually has two completely distinct faces depending on the stage of labor.
It does. It changes both geographically in the body and neurologically in how the signals are transmitted. So during the first stage of labor, when the body is just preparing for birth, the pain is classified as visceral.
Visceral, meaning organ pain.
Right, it originates deep inside the organs. And part of this is simply the cervix stretching and dilating, which is just a mechanical force. But there's also a physiological process happening called uterine ischemia.
Ischemia? I've heard that term in relation to heart attacks, I think. But what does it mean in the context of a uterus?
Well, ischemia simply refers to a localized shortage of blood supply, which by extension means a shortage of oxygen.
Okay.
During a uterine contraction, the massive muscle of the uterus bears down so hard that the arteries supplying it are physically compressed.
Oh, wow.
So for the duration of that contraction, you get this temporary deficit of oxygen in the muscle tissue itself.
Okay, so like if I were doing a wall sit or holding a really heavy dumbbell and my muscles start to get that intense burning ache because the blood can't clear the lactic acid.
That is a very apt comparison. The muscle is essentially suffocating for a brief moment. And the source material notes that this specific visceral pain travels along the T10 to T12 spinal nerves.
Wait, let me stop you there for a second. For those of us who haven't looked at an anatomical chart recently, where exactly are the T10 to T12 nerves? What part of the body is that?
Those are the lower thoracic spinal nerves. So geographically, they map to the area roughly around your belly button and your lower back.
Ah, okay.
And because visceral pain from internal organs is often diffuse and poorly localized, it frequently manifests as referred pain.
Meaning you feel it somewhere else.
Exactly.
Yeah.
That's why a contraction happening inside the uterus is often felt by the patient as this deep, radiating ache wrapping around the lower back, or even shooting down the thighs. It's dull, aching, and widespread.
But then the baby actually starts to move down the birth canal, and the entire pain profile just abruptly shifts gears.
Yes. As the patient transitions into the second stage of labor, which is the pushing phase, the pain becomes somatic.
Somatic pain.
Right. We are no longer dealing with the deep, aching oxygen starvation of the uterine muscle. We are now dealing with the intense visible stretching and distension of the perineal tissues.
And neurologically, that's a completely different wiring system.
Entirely different. These somatic pain signals travel via the pudendal nerve, entering the spinal cord much lower down through the S2 to S4 sacral segments.
Wow, okay.
Because it is somatic rather than visceral, the sensation changes dramatically. It's no longer a diffuse ache. It's usually described as intense, sharp, burning, and highly localized, like the patient knows exactly where the tissue is stretching.
Okay, so you have this barrage of visceral pain signals and then followed by a barrage of somatic pain signals, all just flooding into the spinal cord trying to get up to the brain.
Exactly.
And this brings us to a concept in the text that I found absolutely brilliant, the gate control theory of pain. Because it turns out our nervous system isn't just an open highway, it actually has a bottleneck.
Right. The nervous system doesn't simply wire every single injury directly to the brain's pain centers. The spinal cord acts as this complex processing center, a series of neurological gates that can either allow pain signals to pass through or actually block them.
Yeah, the text got a bit dense here, but the way I pictured it in my head was like a literal traffic jam on a 4-lane highway.
Oh, like that.
Right. Your nerve pathways only have a certain amount of bandwidth. They can only carry a limited number of sensory messages up to the brain at any given moment. So if the highway is totally empty, all those intense pain signals from the stretching cervix and the oxygen-starved uterus just speed right up to the brain without any resistance. The pain is fully registered.
That visualization captures the mechanism perfectly.
But if you start flooding that exact same neurological highway with other non-painful sensory information, like a firm massage, or the sensation of a hot compress, or even intensely focused breathing, you're essentially clogging the 4-lane highway with minivans.
Yep.
The pain signals get stuck in traffic.
They do. The brain literally cannot process the totality of the pain signals because its processing bandwidth is being consumed by the tactile sensation of the massage or the temperature of the compress.
That is so cool.
You're introducing a positive or neutral sensory stimulus to physically close that hypothetical gate in the dorsal horn of the spinal cord. So the patient's perception of pain is measurably diminished without administering a single drop of pharmacological medication.
Which really highlights how incredibly subjective human pain is. It's not just a volume knob that turns up and down purely based on how much tissue is stretching.
Not at all.
The source material spends a lot of time discussing how a person's psychological state, specifically fear and anxiety, can actually make the physical pain objectively worse.
Yeah, anxiety triggers a pretty brutal physiological feedback loop. When a patient experiences excessive fear, the body's sympathetic nervous system, the fight-or-flight response, kicks into high gear.
And releases adrenaline.
Right. The adrenal glands start secreting massive amounts of catecholamines, which are stress hormones like adrenaline.
And what do those stress hormones actually do to the labor process?
They cause systemic vasoconstriction, meaning they narrow the blood vessels, particularly in non-essential areas like the extremities and, crucially, the pelvis.
Oh, wow. Wait, so by panicking and being anxious about the pain, you literally decrease the blood flow to the uterus, which means that uterine ischemia, that temporary oxygen starvation during a contraction we just talked about, gets significantly worse.
Yes.
The anxiety creates a self-fulfilling prophecy.
It creates a tremendous hurdle, for sure. It slows down the progress of labor and amplifies the visceral pain. However, if we connect this to the bigger picture, the human body is remarkably resilient and has a built-in countermeasure.
Okay, good.
As labor progresses and the pain intensifies, the pituitary gland begins to secrete high levels of beta endorphins.
So the body brings its own natural painkillers to the delivery room.
Exactly. Beta endorphins are endogenous opioids. They bind to the exact same receptors in the brain as medications like morphine, naturally raising the patient's pain threshold, and in some cases, even inducing a state of mild euphoria or detachment to help them cope with the trauma.
I love that. And because of this gate control traffic jam we just talked about, caregivers have this wildly diverse toolkit of non-pharmacological tricks to hack the nervous system before they ever reach for a needle.
They do.
Let's look at a few of these, starting with breathing techniques, because we always see this in movies, right? The deep breathing turning into short, rapid breaths. But there is some real science behind it.
Oh, definitely. Breathing techniques serve a dual purpose. First, they act as a profound distraction, taking up cognitive bandwidth and helping to close that pain gate we mentioned.
Right.
The patient might start with slow, deep-paced breathing during the early stages of labor, but as contractions become more intense, they often transition to a quick, shallow pant blow rhythm.
But the text actually issues a major safety alert regarding that specific rapid breathing. Caregivers have to watch out for hyperventilation.
Yes, because when a patient is panting rapidly through intense pain, they risk blowing off way too much carbon dioxide from their lungs. This creates a state called respiratory alkalosis.
Okay, alkalosis. Remind me what is happening chemically in the blood there.
So carbon dioxide in the blood acts as an acid. When you exhale too much of it too quickly, the blood loses that acidity, and its pH level rises, becoming too alkaline.
Ah, got it.
And this chemical imbalance causes very specific, alarming symptoms for the patient: sudden lightheadedness, dizziness, and a pronounced tingling sensation in the fingers, toes, or around the mouth.
Gosh, hearing that as a patient would be terrifying. You're already in immense pain and suddenly your hands go numb.
It is scary.
But the fix for this systemic chemical imbalance is beautifully low-tech.
It really is. The treatment is to simply have the patient breathe into a paper bag, or if a bag isn't available, into their own cupped hands.
How does breathing into a bag fix blood chemistry?
By breathing into confined space, the patient is forced to rebreathe their own exhaled carbon dioxide.
Oh.
Yeah, it rapidly reintroduces that lost acid back into the lungs and the bloodstream. The pH levels balance out almost immediately, and the tingling and dizziness fade away.
That's amazing. Another physical hack that just blew me away in the text was counterpressure. The source mentions applying a very firm object, like a tennis ball or the heel of a hand, directly to the sacrum, the lower spine.
Yes, a classic technique.
And this isn't just a comforting massage, right? It's practically architectural.
It's an entirely structural intervention. In a standard labor, the baby faces the mother's back. But some fetuses present in what we call an occiput posterior position.
Okay.
This means the back of the baby's hard skull, the occiput, is facing backward, pressing directly against the mother's spinal nerves in her lower back as it descends.
Which causes what people call back labor.
Yes, and it is agonizing. It causes severe, continuous back pain that doesn't even fade between contractions.
Oof.
So by applying immense targeted counterpressure with a tennis ball to that specific area of the sacrum, the support person is actually physically lifting the baby's skull off of those sensitive spinal nerves.
You're literally pushing the baby off the nerve. That is incredible.
Okay, but here's where it gets really interesting, and I need you to explain this because I read it 3 times and I still don't fully buy it. The text discusses a procedure called intradermal water blocks.
Ah, yes, an incredibly fascinating technique.
It sounds like medieval torture. The text says that to treat severe back labor, a caregiver can take a syringe and inject tiny amounts of sterile water, like 0.05 to 0.1 milliliters, basically a fraction of a single drop just barely under the skin in the lower back.
Right.
And the text admits this causes intense stinging. How on earth does injecting water to cause more pain somehow solve the problem of back pain? I understand the skepticism. It sounds completely counterintuitive to inflict pain to cure pain, but this relies on a neurological mechanism known as counter-irritation.
Counter-irritation.
Right, it's another more extreme way of hijacking the gate control system. You are essentially fighting a massive fire with a tiny, highly concentrated bit of fire.
Explain the wiring of that. Why does the brain prefer the stinging water over the crushing bone?
Well, the nervous system processes different types of pain at different speeds. The continuous, dull, deep, visceral pain of the uterus and the pressure on the spinal nerves travel along relatively slow-conducting C fibers.
Okay, slow fibers.
But the sudden, sharp, intense stinging of sterile water rapidly expanding the dermal layers of the skin sends a massive, acute alarm signal traveling along much faster, the delta nerve fibers.
So the fast stinging signal races up the spine and beats the slow, dull ache to the brain.
Precisely. The brain prioritizes the sudden, acute, localized threat over the chronic, dull ache. The intense stinging effectively slams the gate shut on the deeper back pain.
Wow.
And the stinging itself only lasts for about a minute or 2. But by the time it fades, the neural pathways have essentially been reset. That tiny fraction of a drop of water can provide significant relief from back labor for up to 2 hours.
That is just brilliant, tricking the brain's own threat assessment software.
It really is.
And speaking of hacking the brain, we have to touch on the environment itself, because the source text explicitly states that continuous emotional support, having a trained doula, a dedicated partner, or a specialized nurse by the bedside at all times is clinically proven to significantly lower a patient's need for epidurals or pain medication.
Yes, and this brings us back to the physiological loop we discussed earlier. A calm, highly supportive environment directly lowers the patient's fear and anxiety.
Right, which lowers the adrenaline.
Exactly. Lower anxiety means less adrenaline and fewer catecholamines in the bloodstream. Fewer stress hormones mean the blood vessels remain dilated, ensuring optimal blood flow and oxygen to the contracting uterus, which literally reduces the physical pain of the ischemia.
So support isn't just comforting, it's a measurable clinical intervention.
It truly is.
But, as the text acknowledges, labor is incredibly unpredictable. Sometimes the baby is positioned awkwardly or the labor goes on for 30 hours. And eventually, no matter how good the doula is or how well you manage the traffic jam in the spinal cord, the neurological gates simply get overwhelmed.
They do. When non-pharmacological methods and emotional support are no longer sufficient to manage the distress, medical professionals have to look at systemic pharmacologic options.
Folks!
Right. But this introduces the most complex puzzle in obstetric medicine. How do you effectively treat the mother's agonizing pain without heavily sedating the infant she is about to deliver?
Because whatever goes into the mother's bloodstream eventually makes its way across the placenta.
That is the precarious tightrope walk. When we use systemic analgesics, these are intravenous opioids like fentanyl, remifentanil, or vitorphanol. They circulate through the entire maternal bloodstream.
Right.
They are highly effective at crossing the blood-brain barrier, providing euphoria, dulling the pain, and allowing the exhausted patient to rest between contractions.
But the danger is that if they cross the mother's blood-brain barrier, they easily cross the placental barrier too.
They do. And the primary side effect we worry about with any opioid is respiratory depression, basically a slowing down of the breathing reflex. If the infant has a high concentration of that opioid in their own tiny bloodstream at the exact moment of birth, they may be born lethargic and struggle to initiate that crucial first breath on their own.
Okay, so this brings me to a mechanical hack hidden in the source material that I found astonishing.
Oh, about the timing.
Yes. The text says that when nurses administer these IV opioids, they don't just push the plunger randomly. They are trained to administer the IV drug during a contraction.
Yeah.
That made zero sense to me at first. The contraction is when she is in maximum agony. Why push the drug then?
It is a phenomenal manipulation of maternal hemodynamics.
Yeah.
Think about what we established earlier about uterine ischemia.
Right. During a contraction, the uterine muscles squeeze so hard that the blood vessels are compressed.
Exactly. So if the nurse pushes the potent opioid into the mother's vavi at the exact peak of the contraction, the medication races through the mother's systemic circulation. It hits her brain, providing the necessary pain relief. But because the blood vessels leading into the uterus are currently clamped tightly shut by the force of the contraction, very little of that newly introduced drug can make it across the placenta to the baby.
It's like closing the blast doors on a spaceship.
That's a great way to picture it.
Right. You seal off the room, release the chemical into the rest of the ship, and keep the sealed room completely uncontaminated.
That is exactly the mechanism. By the time the contraction ends and the uterine blood vessels relax and open back up, the mother's liver and tissues have already begun to absorb and distribute the peak dose of the medication.
Wow.
It maximizes the analgesic benefit for the mother while significantly minimizing the fetal exposure.
But obviously, timing in labor is a huge gamble. What happens if the baby decides to come much faster than anticipated and is born while that IV opioid is still heavily active in the mother's system? Does the baby just stop breathing?
Obstetrics teams are always prepared for that scenario. If an infant is born exhibiting signs of opioid-induced respiratory depression, the medical team has an immediate reversal agent drawn up and ready. It's an opioid antagonist called naloxone, widely known as Narcan.
Wait, the exact same Narcan first responders use for street overdoses?
The exact same molecule. It has an incredibly high affinity for the opioid receptors in the brain.
Okay.
If administered to the newborn, the naloxone effectively kicks the opioid molecules off the receptors and takes their place, promptly reversing the respiratory depression and stimulating the infant's normal breathing drive. It is a vital safety net.
That's reassuring. But even with that safety net, systemic drugs affect the whole body and carry unavoidable risks, which is why the text suggests that the ultimate goal in labor management is often localized pain relief. You don't want to drug the brain, you just want to numb the lower half of the body.
Right.
Which brings us to the absolute heavy hitters of the delivery room, neuraxial anesthesia.
Neuraxial blocks represent the gold standard in obstetric pain management. They offer the most profound, reliable pain relief with the absolute lowest amount of central nervous system depression for both the mother and the newborn.
So we are talking about epidurals and spinal blocks. And the text notes that roughly 75% of women in the U.S. use an epidural during labor, but people use the terms epidural and spinal interchangeably. What is the actual structural difference?
What's fascinating here is the precise microscopic anatomy of the human spine. Both procedures involve injecting numbing medication into the back, but they target completely different anatomical layers.
Okay, break that down for us.
Let's look at an epidural first. The spinal cord is encased in a tough protective membrane called the dura mater.
The protective casing.
Correct. An epidural involves an anesthesiologist using a needle to find the tiny space just outside that casing, the epidural space. They thread a microscopic flexible plastic catheter through the needle into that space and then remove the needle, basically taping the catheter to the patient's back.
So the tube stays in there, allowing for a continuous drip of medication.
Exactly. It bathes the spinal nerves in local anesthetics as they exit the spinal cord. It effectively blocks the pulse signals from the uterus, but because it is outside the spinal fluid, it often preserves enough motor function that the patient can still move her legs slightly and, most importantly, actively push when it's time.
But a spinal block is a different procedure.
Yes, a spinal block is an injection that goes deeper. The needle deliberately pierces through that tough dura mater casing and goes directly into the cerebrospinal fluid that surrounds the cord.
Oh, wow. So there's no catheter left behind.
Usually not. It's typically a single injection of medication. Because the drug goes directly into the spinal fluid, it is remarkably fast-acting and provides a much denser, more complete block of all sensation and motor movement from the chest down.
Right.
Because it acts so quickly and profoundly, spinals are the preferred method for planned or urgent cesarean births.
And this leads to a complication mentioned in the text that blew my mind. Sometimes when an anesthesiologist is trying to place an epidural catheter outside the casing, the needle accidentally advances a millimeter too far and punctures the dura mater.
Yes, it's called a wet tap.
A wet tap.
It is a known risk, and because there is now a microscopic hole in that protective casing, cerebrospinal fluid begins to slowly leak out into the surrounding tissue.
And losing that fluid drops the pressure around the brain, causing what the text calls a spinal headache.
Yes, and it's awful.
It sounded agonizing. Patients describe it as a blinding pain that hits the second they try to sit upright. And I was reading this thinking, how on earth do you put a Band-Aid on a microscopic hole deep inside the human spine?
Well, if conservative treatments like IV fluids, bed rest, and high doses of caffeine don't resolve the leak, the anesthesiologist will perform a procedure called an autologous epidural blood patch.
Explain how this works, because it sounds like science fiction to me.
It's pretty clever. The anesthesia provider will draw approximately 20 milliliters of the patient's own blood from a vein in her arm.
Okay.
Under sterile conditions, they will then slowly inject her own blood back into her back, directly into the epidural space adjacent to where the puncture occurred.
Wait, they inject blood into the spine?
Yes, the body's natural coagulation cascade takes over. The injected blood begins to clot, creating a literal, physical scab over the microscopic tear in the dura mater.
Oh my God.
Once the hole is plugged, the cerebrospinal fluid stops leaking, the pressure equalizes within the spinal column, and the debilitating headache is often resolved almost immediately right on the table.
Patching a structural leak with the patient's own biological material, that is just staggering.
It is a very elegant solution.
Now, before we wrap up today, I want to pivot to a pain management method that the text notes is making a massive comeback. We've talked about IV narcotics and spinal needles, but there's an inhaled option gaining renewed popularity, nitrous oxide, commonly known as laughing gas.
Right. It has been a staple in delivery rooms across the UK and Canada for decades, and it's finally seeing a major resurgence in the United States. In the labor setting, it's administered as a 50.5 mixture of nitrous oxide and oxygen.
But I've had laughing gas at the dentist and it didn't numb my jaw. Does it actually block the pain of a contraction?
It does not eliminate the physical pain signals like an epidural does. The visceral and somatic signals still reach the brain. However, inhaling nitrous oxide triggers the rapid release of massive amounts of dopamine and endorphins.
Okay.
This creates a powerful sense of euphoria and, crucially, cognitive dissociation.
Dissociation meaning like the pain is happening, but you just feel removed from it.
Exactly. The sensation is still there, but the emotional distress attached to the sensation is severed. The patient simply cares about it less. It fundamentally alters the psychological perception of the trauma without paralyzing the muscles or sedating the infant.
And the text highlights a really strict rule about how this gas is administered. The nurse doesn't hold the mask. the patient has to hold the mask over her own face. Why is that so important?
It's a brilliant built-in safety mechanism. The patient places the mask over her face as she feels a contraction building and inhales deeply. If she breathes in too much gas and becomes overly drowsy, her hand muscles naturally relax.
Oh, and the mask falls away.
Exactly. The mask drops away from her face and she begins breathing normal room air immediately. It is physically impossible to accidentally overdose.
That is so smart.
But beyond safety, it provides an immense psychological benefit. It gives the patient total autonomy and control over her own pain management in a situation where she otherwise might feel helpless.
So what does this all mean? We have covered a truly staggering amount of ground today. From tricking the spinal cord's traffic controllers with tennis balls and rapidly panting into paper bags to, timing IV pushes like spaceship blast doors to protect a baby,
Yeah, we covered a lot.
and literally patching spinal fluid leaks with a patient's own blood. This text proves that labor pain management isn't just a list of drugs, it's an absolute marvel of adapting to human physiology.
It truly is. And I think the major takeaway here, whether you ever personally experience labor or support someone who does, or just find biology fascinating, is understanding the profound complexity of pain.
Right.
Pain is not just a raw physiological input. It is a highly subjective experience shaped by the brain. It is heavily influenced by your anxiety levels, your environment, and the emotional support you receive. Examining how medicine manages the extreme pain of childbirth provides incredible insight into how the human nervous system processes stress in almost any situation.
It's so true. Which brings me to a final thought I want to leave you with today. We saw clear clinical evidence in the source material that continuous positive emotional support, like having a doula holding your hand and talking you through the fear, physically changes a patient's neurological perception of pain.
Measurably so.
It demonstrably lowers stress hormones and drastically reduces the need for heavy systemic narcotics. Human connection is a literal, measurable analgesic in the delivery room.
Which raises an incredibly important question for modern medicine.
Right. If we have the hard clinical data proving that human connection and a calm, supportive environment are just as vital to physiological pain management as the powerful medications we inject, well, shouldn't we be designing all of our hospitals for every single type of surgery or chronic pain treatment around that exact same principle? It's something to mull over. We'll see you next time on The Deep Dive.